As with a number of mental disorders, there's hypotheses regarding imbalances of different types of neurotransmitters within the brain. And it's thought that especially the monoamine systems, so neural networks that secrete or release noradrenaline, dopamine, serotonin, are not as there's not as strong a release there as the opposing sort of acetylcholinergic pathways. So the different neural networks are working in tandem and working against each other, and there seems to be a deficit of monoamines in some of these in people with bipolar disorder. Now, another feature is that with regard to the neurobiology is that the prior psychotic episodes, so that a person has been sick, and that actually, the more times that they have an episode, the more it will cause changes in the brain, and that will increase the probability of future episodes and continually exacerbating the neuropathology. This is known as a kindling hypothesis, like you use a little bit of kindling to set a fire, and it starts to sort of blaze, and it sort of increases and increases. This is the metaphor. So basically, the more a person has episodes, the more there is a change in the brain, and the more likely that they have more and worse episodes in the future. So it's very, very important to try and control the condition in order for it not to get worse. So there's known to be abnormal levels of neurotransmitters in bipolar disorder, and the balance can be modulated by drugs. Just to remind you how the monoamine neurotransmitters, they're produced in the nerve. This is a nerve terminal, and they're produced and they're packaged in secretory vesicles, which are then, when there's a signal comes down, an action potential comes down this neuron, it causes the release of the neurotransmitter into the synaptic cleft. It binds with receptors on the postsynaptic membrane, and then it's sort of turned off by being taken back up into the nerve terminal. In addition, the neurotransmitter is broken down by monoamine oxidase. So the point is that if you want to increase the amount of noradrenaline or serotonin or dopamine, depending on the type of neuron we're talking about, in the synaptic cleft, and therefore increase its action, you need to either block its reuptake or block its breakdown in the actual nerve terminal as well. So we can use drugs to modulate the activity and availability of neurotransmitters. So tricyclic antidepressants and non-specific reuptake inhibitors all help to sort of increase the amount of monoamines in the synapse. Also, monoamine oxidase inhibitors have been used to stop the breakdown of the monoamines. Now, the early ones were a problem because they were irreversible, but now we've got ones that are reversible, and so there's not the dietary problems and things that high in tyrosine could actually cause a serotonin syndrome or an autonomic crisis. And nowadays, selective serotonin reuptake inhibitors and other reuptake inhibitors are the ones that sort of are used more than these older style antidepressants. Now, I've shown you this slide before with the we have a sort of a balance in the brain between monoamines and cholinergic neurons. They're sort of working in tandem, sort of balancing functions in the brain. This is a bit simplistic, of course. And in depression, there seems to be less of the on the monoamine side, particularly serotonin and things, and more of an imbalance towards the cholinergic neurons. Well, that's fine for depression, and if in mania it's the opposite, there seems to be less of the activity in the cholinergic neurons and more in the, say, dopaminergic and noradrenergic neurons and glutamatergic. So the thing is that in bipolar disorder we have depression and mania. Now, antidepressants can be used to counteract effects in the depressive side, but of course in a manic episodes that's sort of opposite. So how do we treat bipolar disorder with drugs? In a manic episode, antidepressants could actually exacerbate or even trigger a manic episode. The answers came start in 1949 with an Australian psychiatrist called John Cade, who was working with returned servicemen in the Royal Park Psychiatric Hospital here in Melbourne, and he felt, and in fact his father actually had been a psychiatrist too, working with the First World War veterans as well. So he was very familiar with effects of depression and also mania and bipolar disorder. And he, in 1949, he had the hypothesis that mental illness was actually due to some sort of toxic agent. And he was looking at things like uric acid and things as a possible toxin, and doing experiments with guinea pigs. But he was, in order to actually deliver the urate, he was combining it with the lithium salts and making a lithium salt out of it. And he found that by careful, controlled experiment, that the lithium urate made the guinea pigs docile, but also discovered that it was actually the lithium that was the active principle, not urate. So he tested it on himself to see, looked at toxicity. Of course, that would not be permissible nowadays, but and then he had 10 manic patients who he could not otherwise treat adequately, and treating them with the lithium, they showed significant decrease in symptoms. And so this was the first instance of the use of lithium as a mood stabilizer. He discovered that there were toxicity issues, and so he abandoned the experiments, and it was then taken up by a Scandinavian psychiatrist towards the end of the 50s, and lithium has become the mainstay of mood stabilizers and the treatment of things like bipolar disorder. The mechanisms and how this works is not well understood, as a lot of these drugs are, but there seem to be intracellular effects. It's known to affect certain pathways, enzymic pathways within the cells that influence cellular plasticity, so the ability for cells to make new connections, and also their resilience, their ability to cope with stressors. And it directly induces enzymic systems at the transcription level. So it turns on genes and promotes this neuroplasticity, as I said, but also, as I said, cellular resistance to stressors. And possibly it might promote neurogenesis in adults, but we're not sure about that. Subsequent to lithium, other mood stabilizers have been found. amongst the anticonvulsants that sort of are used to treat things like epilepsy. So sodium valproate is one such thing, and it might have similar targets to lithium, and reduces the kindling that we were talking about before, the sort of the small aberrations that then can sort of spread to larger psychotic episodes. So in bipolar disorder, there seems to be certainly an impairment of cellular resilience, the ability of cells to cope with stressors. There seems to be reduction in volumes, and also observed a cell death and atrophy. And this is observed in other mood disorders too. And obviously, as I said, mood disorders that seem to be sharing a similar underlying genetic predisposition in many cases, although so there are common genes there. So it's not surprising that other mood disorders we see these things too. There seem to be genetic neurodevelopmental factors that are sort of at work here, as I said, and also too, of course, repeated affective episodes cause further problems with the cells, and as the illness progresses, it sort of it seems to be a degenerative aspect to it. And stress and depression impair cellular resilience, and that, as I say, is basically the ability for cells to cope with stressors. These sorts of factors reduce levels of certain what we call neurotrophic factors that protect the cells against damage, and particularly things like free radicals and other sort of oxidative agents, and also excessive intracellular calcium. We'll talk more about what calcium can do. But these things, there's a substance called BDNF, which is a neurotrophic factor that helps in this. And also too, the stress and depression increase glutamatergic transmission, so activation of the so-called NMDA and non-NMDA receptors within the brain, and this overstimulates a lot of cells, and we get what a situation that's called excitotoxicity. Basically, overstimulating areas of the brain will actually cause the release of intracellular calcium, and that's, we'll see, as a problem, and also to deplete reserves, and therefore it can decrease the ability of cells to actually repair themselves, and also to actually function properly, overall reducing the energy capacity of the cells. So calcium has a number of intracellular effects, and so if you keep stimulating cells over and over, there'll be a rise in intracellular calcium, and that can actually cause it can be released after cell damage, but just by excitotoxicity, we can get free calcium, and that can activate a number of enzymic systems that need calcium as a cofactor, and so it activates its protein kinases, which causes breakdown of proteins and phosphorylation of proteins, and activation of other enzymes, and also the fragmentation of nucleic acid and chromatin. These phospholipases that are activated by the protein kinases can actually lead to membrane damage, and then we have other proteases that can cause the actual cytoskeleton, so the sort of the organisation structure within the cell to be damaged. And that can actually lead to things like cell swelling too. That sort of there's various pumps and things are affected, and we can get osmotic regulation is affected, and we can get the movement of water across the cell membrane. And of course, then other sort of enzymes that sort of damage directly the nucleic acid can give rise to be activated by free calcium. So over stimulation of cells can actually lead to quite significant serious cell damage and loss of resilience. So administration of various antidepressants increases the neurotrophic factors such as BDNF and its receptor, and so therefore we get enhanced cell survival by activating these so-called cytoprotective pathways that sort of enable it to protect it against stressors. And we get the expression of all sorts of proteins that help to sort of protect the cells too, such as this BCL2. And one of the things that this example does, it impairs the release of calcium and cytochrome C, and so all those things that we were just talking about helps prevent that sort of thing. Reduces the activation of caspase, which is a cell death inducing enzyme that sort of is activated when cells undergo apoptosis or programmed cell death. And also too enhance the uptake of calcium into mitochondria, so basically sequestering the calcium away from other parts of the cell, preventing it from causing the problems. And so it can reverse the effects of stressors and things, and the increase of calcium and such like, and other problems. So lithium and valproate also upregulate BCL2, and basically inhibit various the transduction of signals from neurotransmitters for glutamate and things of that nature, that then will reduce the excitability of the cell and so reduce kindling. But also too will have this neuroprotective effect. Some of the neurotrophic effects can include the outgrowth of neurites, so the formation of new connections, and also general neuronal resilience, as we've talked about, but also remodeling, so the ability for the neurons to repair themselves, keep themselves healthy, and as I said, produce new synapses and generally function as they should. This is a very complex graph. It just shows you some of the areas where lithium and valproate might work. So in upregulating BCL2, it can help with sequestration of calcium, and counteract a number of effects in various parts of the cell, basically through these activating some of these neurotrophic factors such as BCL2, and help to maintain energy regulation. So we're starting to understand how the mood stabilizers do actually help intracellular systems to stabilize the cell, help it to sort of maintain resilience and combat stress, and therefore and also too to maintain normal healthy regeneration and formation of new synapses and things. So how do we treat it? how do we treat bipolar disorder? Well, there are a number of pharmacological treatments. We've talked about lithium, that's the first line of treatment, the mood stabilizers. There's valproate, which is anticonvulsant, and it goes under the name of lamotrigine. Antidepressants are also used, but really, of course, they need to be used in combination with mood stabilizers, and they're often discontinued when there's the onset of the manic episodes, because, of course, that would be counterproductive. Antipsychotics are also used, and these affect the more cognitive areas of the brain and allow for emotional regulation. And they're especially useful for acute treatment of mania. And atypical antipsychotics are used quite often now, such as olanzapine, and also aripiprazole, which is under the name of Abilify, has become quite widespread in its use. These seem to interfere with dopamine receptors and possibly serotonergic receptors too within the cognitive areas of the brain, and so help to sort of maintain mood stability and stabilize general sort of affect. We don't really fully understand how these things work, but it sort of damps down psychotic episodes. Now, the thing is about all drugs is they have side effects. They're sort of sometimes, and the trick is to balance the efficacy against side effects. So, if the good effects outweigh the side effects, well, so that's good. But if and we're being all different, some drugs are better in some people than others in producing more positive effects. So really, in terms of bipolar disorder, the phase of the illness obviously is very important in choosing the type of medication, acute episodes or for prophylaxis. So we might need some antipsychotics or antidepressants in acute episodes, but prophylaxis, mood stabilizers and things are probably more useful. Also, just how severe the symptoms are and whether we're talking about bipolar 1 or 2 or cyclothymia. And and just where the symptoms are, and and the thing is that all people are different, of course, and all people with bipolar disorder are slightly different, and so it's not a one-size-fits-all type of category. Whether there's rapid cycling is also a thing, but also too, because it is there's a large genetic component, there will be likely to be a family history of response and tolerability to the drug, and both within the patient and also as a family history, and this is also an important consideration. Also, their current medication, there were some significant contraindications and interactivity with some things, and medical psychiatric comorbidity. So what other issues are there? Also, of course, as I said, the side effects. Sometimes the side effects are greater in some people than others. Some people tolerate certain things better than others and respond better. So these sorts of things need to be taken to, and so the current medication and whether there are drug interactions with different things. Also things like pregnancy and lactation, there are considerations there. And patient preferences. Some patients find certain drugs are really very difficult to cope with. Some drugs are better. Some people just really do not want to be treated, of course, that's their preference. Now, drugs are not the only answer, and certainly they can't be, because they're not the be-all and end-all. So there are other treatments, biological treatments. Electroconvulsive therapy is used in some cases for very intractable depression, particularly. Transcranial magnetic stimulation, in which a large magnetic field is applied to a particular part of the brain, and that stimulates areas beneath that and that is seen to be effective in some cases. More in there's some evidence that it's particularly effective in things like PTSD and such like. We'll talk more about that later. But certainly there's been some trials of TMS in people with affective disorders such as bipolar. There are psychological treatments, so cognitive behavioural therapy, acceptance and commitment therapy, interpersonal therapy, schema therapy, all these things. Your occupational therapy lecturers will talk more about these things, doubtless. And so, but also social support. As with any mental illness, the social environment is very important, and support networks. Sadly, a lot of people with mental illness don't have that that general support. They may have driven it away by their, from their due to the mental illness and things. But social support is really important to try and sort of help the person re-establish their lives, and that brings us to the lifestyle modifications, such as and as with a lot of mental illness, exercise has very, very good effects generally. It has, in bipolar disorder, it actually can have positive or negative effects. Light exercise, general exercise is generally quite good, but when a person is experiencing particularly manic episodes, it can actually, the manic episodes can drive the taking exercise to the extreme, and actually sort of the exercise itself can be sort of unfortunately with bipolar disorder, there can be positive and negative effects of exercise. By and large, exercise is always a positive, but in this case there are some negatives. Now, if you're interested in looking further, the Royal Australian New Zealand College of Psychiatry has a number of some documents about with guidelines for mood disorders, and it's quite an extensive document if you want to have a look at it. But one of the things that comes from this is that any sort of treatment has the prescribed model is what's described as biopsychosocial and lifestyle model, or BPSL. And so we have treatment for the biological aspect of the disease, and there's no doubt that it is an organic disease, as we've seen. And we've talked about some of the therapies there, the psychological treatments of various sorts. In this domain, we have social treatments, so family, psychoeducation, family and friends, formal support groups, community groups, caregivers, all the rest of it, that can help sort of, and then lifestyle treatments, so diet, exercise, diet, smoking cessation, alcohol cessation, all those sorts of things, and sleep. Sleep is very, very important, of course. And so all these things are looked at as a whole. So there's a holistic approach to treatment, and one cannot be solely effective. One sort of aspect of treatment cannot be solely effective. It needs to be the whole sort of gamut in this model. So, as I said, a lot of information on the RANZCP website. Thank you very much for listening. That's the end of this lecture.